Hi, I'm Claudette from Pre-operative Talk Physiotherapy, and we will be discussing the ins and outs following your hip replacement over the first 6 weeks. You will be coming in for surgery because you are experiencing pain in your hip or have referral pains down the leg or up into your back. Your range of movement may be limited, impacting normal day-to-day routines such as tying your shoelace or washing your foot. You may also be limping. On X-ray, you will be able to see joint space narrowing due to degeneration of your hip. Your head of femur will have lost cartilage and you are now experiencing bone-on-bone pain. Once you have your date for surgery booked, you will be advised what time you should get to the hospital. It will generally be on the morning of the surgery at 5:45 a.m. Once you are up in the ward, you will be required to complete forms, so please bring a black pen and reading glasses if necessary to make this process easier. Also, a list of your current medication will help with the completion of the forms. The orthopedic surgeon, the anaesthetist, and the physiotherapist will do a pre-surgery assessment on you. A shower with disinfected soap is required the night before your surgery or before theatre. Your doctor's receptionist will advise you which they require. Finally, before you head down to theatre, you will be prepared and draped. Please advise the nursing staff if you are allergic to iodine so an alternative can be made. When you arrive in theatre, the anaesthetist will insert a drip on your arm and give you some light sedation. The surgery is performed with a combination of a spinal block and light general anesthetic. This gives the surgeon the best operating conditions. And no, you won't feel the spinal needle going in, and yes, you will be asleep during the procedure. This picture shows you how you are draped and positioned on your back for an anterolateral hip approach. There are 3 surgical approaches used for a hip replacement: anterolateral, anterior, and posterior. The surgical approach is selected based on your surgeon's experience and preference. Research on all the approaches show a similar outcome at 6 weeks. The anterolateral approach will have the incision more towards the side seam of your pants. The anterior approach will have the incision towards the front of your thigh in the groin area. Picture A is the first part of surgery, which is the skin incision and then navigating through the muscle planes to reach the joint. Retractors are put in for a clear view. The hip is then dislocated to expose the head of femur. Picture B is showing the head of femur, which is then cut off at the neck area to allow more space to access the acetabulum. In picture C, we show the exposed acetabulum. It needs to be reamed out so that fresh, healthy bone is ready to grow onto the liner and is the correct shape and size for the prosthesis. In picture D, this is the reaming machine in the acetabulum. The second aspect of surgery is on the femoral end. Picture E shows the exposed neck of femur. The femoral canal needs to be cleared and widened if necessary to insert the stem down it. This is done carefully so as not to cause any damage to the bone. The correct size prosthesis is used for a snug fit. Picture F shows the stem perfectly positioned in the femur. The surgeons then check leg length accuracy. There are 4 components that make up the hip replacement: the titanium liner, which is press fit into the joint, the ceramic cup that fits securely into the liner, the ceramic ball, which fits onto the stem, and the stem made of titanium. The ceramic on ceramic gives off the least wear particles over time. Once all these components are in, the surgeon checks that there is no impingement and that there is functional range of movement in the joint. Then all that's left to do is suture up the soft tissue and close the wound with subcut stitches. You are then taken to the recovery room and slowly woken up. When ready, a post-op x-ray is done and then you head back up to the ward. When you're up in the ward, you are awake, a little bit groggy, but your legs will still be numb for another hour or 2. A wedge pillow will be placed between your legs and anti-embolic stockings put on. There is no catheter put in, so the ladies will need to use the bedpan and men a urinal bottle to pass urine during the night. Your drip will stay up and running all night. There will be discomfort during the night, but no real pain, and this will be continuously managed by the nursing staff. You'll be woken up every hour for your blood pressure, temperature, and oxygen saturation level checks. Please do not try to get out of bed. We don't want to risk a fall. It's going to be a long night, so hang in there. To prevent DVT complications, anti-embolic stockings are worn. They help to control superficial swelling and assist by alleviating the load placed on the deep veins. The stocking is to be worn on the operated leg for 2 weeks, day and night, and then for a further 2 weeks just during the day. You will also be prescribed a blood thinner for a 4 to 8 week period, dependent on your surgeon's preference. The most important way to prevent complications is to move. You are not sick and should not stay in bed all day. We call the day of operation day 0. Once back in the ward, hourly observations will take place. The nurses will control your pain. You can do a few circulatory exercises and deep breathing techniques that the physio has shown you in the pre-assessment. The next day, day 1, the doctor will do his ward round. From there, the drip will be removed, medication prescribed, and the dressing changed. The physio will then do additional bed exercises, show you how to get up and out of bed safely, teach you how to mobilize with a walker, and later in the day, crutches. You'll be shown how to safely get on and off chairs and manage toilet transfers. You will also be taught how to go up and down stairs correctly and do exercises in standing. You will receive your surgical information booklet and set up the first post-operative appointment if it has not already been done. If you are coping and the physio is happy with your progress, you will be discharged that same day around 3 p.m. If you stayed the second night, the next morning the doctor will see you again and discharge you. The physiotherapist will continue with mobilizing, doing all exercises, and practicing going up and down stairs. You will be discharged before 12 p.m. that day. If you live alone, you need to put plans in place and organize your discharge venue prior to surgery. Home is the best place to go back to, so try get a family member or friend to come and stay with you, or alternatively, you can go stay with them for a week or 2. There is the option of a step-down facility, although they do not always have beds available, and your medical aid may not cover this benefit. Please investigate prior to your surgery which step-down you would like to use and if your medical aid will pay. On a more practical note, what to wear in hospital, do not bring tight-fitting pants as your leg will be swollen and this will be very uncomfortable. Ladies should stick to nighties and men boxer shorts and a t-shirt. Gowns are not always needed, but a lighter one may be brought. Ensure you have sensible slip-on shoes or slippers with a heel counter. Some of the pain medication prescribed often causes constipation. Please be aware of this and manage it accordingly. While the surgery is performed as minimally invasive surgery, your soft tissue needs time to heal, your bone needs time to grow onto the prosthesis, and your body needs time to recover from the effects of surgery and anesthesia. There is a small risk of dislocation of the hip for the first 6 weeks. To minimize this risk further, a few rules are in place for 4 weeks post-operatively. Rule 1. Do not bend too far forwards. Keep a 90-degree angle between your operated leg and your chest. Your hands should never be reaching past your knees. So sit on a higher, firmer chair with armrests. Get help to put on your stocking and shoes. There will be no bathing for 6 weeks, only showering. Rule number 2. Do not cross your legs. If we take a line down the middle of you, your operated leg should never cross that midline. So do not cross your ankles while in bed. You are also not allowed to sleep on your side for 2 weeks. You must sleep on your back. After 2 weeks, you can then start lying on either side with a pillow between your knees. Rule number 3, do not twist or rotate your body. In all positions, attempt to move your trunk and legs as one block or unit. Do not twist your upper body to reach your bedside table in lying or sitting. When changing direction in standing, turn towards your operated side. You will use 2 crutches for the first 2 weeks. At your 2-week post-operative check, we will teach you how to use 1 crutch. You will then use 1 crutch indoors and continue using 2 outdoors and slowly wean 1 crutch use outdoors over 2 weeks. At 4 weeks post-operatively, you can start walking without crutches indoors, but still continue using 1 crutch outdoors. Again, weaning the outdoor crutch use. We will guide you through the weaning process. When getting out of bed, you will move yourself closer to the non-operated leg's edge of the bed and carefully swivel around, keeping your body as one unit. To sit down, make sure the chair or bed or toilet is right behind you. Slide your operated leg forward, feel for the armrest or a basin to hold onto, and slowly lower yourself. Going up and down stairs is simple. You do it one step at a time and your non-operated leg is doing all the work. We will teach you how to do this in hospital, but remember, the good goes up to heaven and the bad goes down to hell. For showering, you may prefer to sit on a plastic chair inside the shower. Treat the lip of the shower as a normal step. When dressing, you will need help to put on your stocking and shoes. Bright tongs work well for assisting with getting your underwear and pants on. Your first post-operative appointment is at 2 weeks, and this is with your surgeon and the physiotherapist. Your dressing will be removed and assessed. We will discuss your progress and any difficulties and assess what changes can be made. We will also teach you how to use one crutch and lie on your side, etc. We recommend an appointment at 4 weeks post-operatively with the physio. There is a huge rule change and we need to work on your range of movement, muscle strength and balance. Gait re-education is also needed to start walking without a crutch and without a limp. At 6 weeks post-operatively, you have an appointment with your surgeon and the physiotherapist. An X-ray is required to be done prior to your visit. Gait rehabilitation is continued and a discussion of return to sport takes place. It is very unlikely, but if we are not happy with your progress at this stage, a 12-week appointment may be booked. When it comes to returning to normal life, following our assessment, you may be able to drive from 2 to 3 weeks post-operatively. With work, depending on your level of activity required for work and our assessment, you may start part-time work from 2 to 3 weeks, and full-time you may return between 4 to 6 weeks. With regards to gym, stationary bike cycling can be begun at 2 to 3 weeks post-op, gentle movement in the water from 3 weeks, and full swimming at 4 weeks. The treadmill and circuit machines should wait until 6 weeks post-operative. If you plan any overseas travel within the first 12 months after surgery, the World Health Organization says you are at a higher risk of getting a clot on long-haul flights. We recommend taking a blood thinner for your flights prior to departure. You can arrange this with your orthopedic surgeon. You will probably set off metal detectors. Let the security know you've had a joint replacement. There is a potential risk of infection of your hip prosthesis for life. Update your records with your doctor and dentist. An antibiotic may be prescribed prior to certain procedures to cover you if necessary. We want your joint to last as long as possible. You can do this by decreasing the load on your hip by keeping your weight to within healthy limits. Avoid jarring activities and wear appropriate footwear for all activities. And finally, your body takes time to heal. Pushing yourself excessively and overdoing it won't rehabilitate you faster. Neither will excessive rest and immobility. Listen to your body signals and obey our rules. Our team is here to help you with your recovery every step of the way. If you have any problems, worries, or concerns, contact us.